Hi, my name is Sergey Motov, and I welcome you to our monthly EMedHome ED Pain Management videocast. Before we proceed, I want to thank you all, our loyal listeners and subscribers, for continued patronage, and I want to wish you all, you and your family, happy and healthy New Year. Today we're going to talk about therapeutic options for acute headache management in the emergency department. And the reason I want to talk about headache is that we have a variety of medications, some of them pure analgesics, some of them non, have a variety of combinations that we use in our emergency departments. And what I'm going to do for the next 20 to 30 minutes or so, I am going to provide a brief overview, what is good, what is not so good, what is fantastic, and at the end we're going to come up with the same framework at what constitutes an algorithm on managing particularly migraine headache in the emergency department. As always, I have nothing financial to disclose. And as far as introduction goes, some of you may not be aware of it, that headache is the 5th most common chief complaint for which patients come to the emergency department. It constitutes of 2% of all ED visits in the United States. Numerical-wise, 2.1 million patients present per year in ED with primary headache disorders, of whom about 1 million of patients present to the emergency department with acute migraine headache or exacerbation of chronic migraine headache. For the sake of today's presentation, I'm only going to be focusing on primary headache disorders that include tension type of headache, migraine headache, cluster headache, and headache associated with the coughing, severe extreme exercise, sexual intercourse, or thunderclap headache that has nothing to do with the subarachnoid hemorrhage. It's just the title of the headache. Briefly, without getting into much of the pathophysiology, the question is, why do we get headaches? And in simple words is, why does it hurt? What it just so happened that a neurovascular theory, it seems to be more plausible when it comes to explanation of having primary headache disorders. Cortical depression stimulates cerebral vessels, neurons, which in turn release a fair amount of variety of vasoactive peptides that causes local inflammation. Those vasoactive peptides in turn activates nerve ganglion, particularly trigeminal ganglia and ganglia within cervical plexuses. Activation of those vasopeptides and ganglia lead to massive neurogenic inflammation that in turn leads to vasodilation that causes a pain. When it comes to therapeutic options that we have in our emergency department, we do have a variety of analgesic and non-analgesic medications. NSAIDs, Neuroleptics, Butyrophenones, Triptans, ergots, opioids, steroids. But for the sake of today's presentations, I'm going to make a few disclaimers. First, I am not going to discuss in details the role of magnesium and valproic acid in managing acute migraine headache or even tension type of headache. There's a paucity of data supports its use, but as I said, I'm going to focus in on something different, a medication that we use more commonly. And when it comes to use of ergots in the emergency department for primary headache disorders, there's a one systematic review that included 11 trials, failed to demonstrate any analgesic superiority of DHT, stands for dihydroergotamine, in comparison to sumatriptan or antiemetics or neuroleptics. However, combination of ergots and antiemetics actually was found superior to meperidine, valproic acid, and ketorolac. However, use of ergots is associated with a significant amount of side effects, and because of ease of use of sumatriptans and other medications, ergots are not really favorite type of medication that we should be using in our emergency departments for patients with a headache. So without further ado, I'm going to proceed with our first class of medications, non-steroidal anti-inflammatory medications. Based on available data, NSAIDs, particularly in oral form, and most common representative agent is ibuprofen, are considered to be first-line therapy for patients with acute headache that can take oral medication, that don't have any allergy, or do not have severe side effects or comorbidities that would preclude them from taking these medications. The way that NSAIDs alleviate headache is by decreasing inflammation, by inhibiting COX-1, COX-2 enzymatic pathways. Some of the most commonly encountered side effects of NSAIDs are nausea, dizziness, abdominal pain. Caution should be instituted or executed for patients with history of gastrointestinal bleeding, active peptic ulcer disease or gastritis, renal insufficiency, labile hypertension, as well as congestive heart failure. As I mentioned, ibuprofen remains the preferred agent when patient can tolerate PO medication. However, should patient have severe headache and unable to tolerate PO, intravenous ketorolac should be used if you desire to proceed with non-steroidal anti-inflammatory medications. Let's look at some of the data that supports or refute the use of NSAIDs in emergency department for headaches. First, we're going to look at the study of Susie Sang, who put together a systematic review and meta-analysis evaluating analgesic efficacy and safety of low-dose ibuprofen. Low dose meaning 200 and 400 milligram. Authors reviewed Medline, EMBase, Evidence-Based Medicine Review, and Cochrane Library up to 2006. Trials that were included in this review included prospective randomized, double-blind, placebo-controlled trial when ibuprofen was used for at least one migraine attack for patients at least older than 16 years of age. Primary outcome of the systematic review were overall headache relief, pain-free episode at 2 hours in the emergency department, sustained pain-free episode up to 24 hours, and lastly, relief of other migraine-associated symptoms. Results of the systematic review showed that when ibuprofen was given at 200 milligram and 400 milligram, it was found to be much more effective than placebo in reducing pain intensity and eliminating pain, in other words, associated with a pain-free interval within 2 hours in the emergency department. For 200 milligram dose, number needed to treat to have significant decrease in pain, and number needed to treat to have significant amount of pain-free at 2 hours episodes was 8 and 13 respectively. At 24 hours, however, neither medication dose, either 200 milligram or 400 milligram, provide superior analgesic efficacy in comparison to placebo. When it comes to 400 milligram dose, it was found that this dose provides additional decrease in photophobia, in phonophobia in 30 and 49% of patients respectively. Similar to it, Rabi and colleagues conducted Cochrane database systematic review evaluating analgesic efficacy of ibuprofen with and without antiemetics for treating acute migraine headache in adults. 9 studies were included in systematic review, over 4,000 patients with over 5,000 attacks. Ibuprofen was compared to placebo or active comparator. Additionally, none of the study of those 9 trials showed that any of the patients were self-administered antiemetics. So basically all these trials were comparing pure ibuprofen. Primary outcomes of the study was safety and efficacy, which translates into number needed to treat to have a headache decrease or pain-free episode at 2 hours and 24 hours, as well as relative risks and number needed to harm. Results show that when ibuprofen at 400 milligram dose was compared to placebo, it was found to be much more effective in 2 hours pain-free episodes, headache relief at 2 hours, and 24 hours sustained headache relief in comparison to placebo. Number needed to treat for 3 aforementioned objectives were 7, 3, and 4 respectively. Ibuprofen at 200 milligram dose in comparison to placebo showed analgesics superiority with respect to relieving pain at 2 hours, having pain-free episode at 2 hours, and 24-hour sustained headache relief as well. However, 200 milligram dose was found to be slightly less efficacious than 400 milligram dose. In addition, 400 milligram dose, 200 milligram dose, and placebo had similar degree and similar rates of side effects. Taggart and colleagues conduct another systematic review evaluating analgesic efficacy and safety, or I would say even feasibility, of intravenous ketorolac in order to treat patients with acute migraine. Authors searched Medline, EMBase, Cochrane, and CNAL, and they were comparing IV ketorolac alone or in combination with other abortive therapy to placebo. 8 trials were included in this systematic review that included 321 patients, of which 141 patients received ketorolac. Results showed that at 60 minutes, ketorolac and meperidine had similar pain scores, translating to similar analgesic efficacy. However, group receiving meperidine had significantly higher rates of side effects. Ketorolac was found to be more effective than intranasal sumatriptan. At 60 minutes, several trials showed that there was no difference between ketorolac and phenothiazines. However, Those trials that compare ketorolac and phenothiazine were extremely heterogeneous. Thus, results of this particular statement has to be validated. In addition, ketorolac had relatively similar side effects with comparators. Others' conclusion that ketorolac represents fair and good alternative and relatively safe alternative to opioids and phenothiazines when it comes to treating acute migraine headache. And lastly, just relatively recently, 2 years ago, Dr. Friedman and colleagues conducted a prospective, randomized, controlled trial of patients presenting to emergency department with non-migraine, non-cluster type of headache, mostly tension type of headache, who were to receive intravenous metoclopramide at 20 milligram with diphenhydramine at 25 milligram dose. And this patient were compared to intravenous ketorolac given at 30 milligram intravenously. Primary outcome of the study, change in pain score at 1 hour. Pain was assessed at baseline and every 20 minutes up to 1 hour. And secondary outcome include a rates of rescue analgesia, overall satisfaction, pain-free, headache-free intervals at 2 and 24 hours. Results of the study showed that morphine diphenhydramine group had significantly greater change in pain score at 1 hour in comparison to ketorolac group, 5 versus 3. In addition to it, morphine, metoclopramide, and diphenhydramine group were superior for the 3 secondary outcomes. Percentage of patients or number of patients that had a headache relief without rescue medication, percentage or number of patients that had sustained headache freedom at 2 and 24 hours, and percentage of patients or number of patients who wished to receive the same medication again. Numbers were 3, 6, and 7, which was significantly better and larger than patients who received intravenous ketorolac. Author's conclusion was that combination of metoclopramide and diphenhydramine is superior to intravenous ketorolac when it comes to treating patients with tension type of headache. Now we leave NSAIDs alone and we're moving to the next class of medication. We're going to talk about neuroleptics, known as antiemetics, familiar to us, practicing ED physicians. Mechanism of action is the act on limbic system and basal ganglia to modulate headache by modulating neurogenic inflammation, decreasing amount of inflammation and release of vasoactive peptides, thus preventing massive vasodilation and controlling headache. Most of the neuroleptics possess anti-dopaminergic, anti-serotonergic, antihistamine, and some of them possess even anticholinergic effects. Most commonly used neuroleptics in our emergency departments are metoclopramide, prochlorperazine, and recently chlorpromazine. Now let's review some of the literature that either supports or again refute use of neuroleptics or antiemetics in our emergency department for a variety type of headaches. First study by Dr. Friedman and colleagues in 2008. It was a randomized double-blind controlled trial of 77 patients who presented to emergency department with acute migraine headache. They were randomized to receive intravenous prochlorperazine, known as Acampazine, at 10 milligram versus IV metoclopramide, known as Reglan, at 20 milligram dose over 15 minutes. Prior to medication, 25 milligram of diphenhydramine was administered to each group. Primary outcome of the study was change in pain score at 1 hour, 2 hours, and at 24 hours via telephone interviews. Results of the study showed that both groups who received intravenous prochlorperazine or intravenous metoclopramide had similar change in pain score at 1 hour by 5 points each. Both groups had similar change in pain score at 2 hours and 24 hours. However, when it comes to side effect profile, metoclopramide group had significantly less side effects. 32% of patients had side effects in comparison to 46% in the group of prochlorperazine patients. Lastly, 77% in prochlorperazine group versus 73% in metoclopramide group would prefer same medication in the future. Author's conclusion was that either metoclopramide with diphenhydramine or prochlorperazine with diphenhydramine provide acceptable headache relief in patients with acute migraine in the emergency department. Differently though, about 20 years ago, one of the first studies by Coppola and colleagues, we're going back to 1995, conducted similarly randomized prospective double-blind placebo-controlled trial of 70 patients who present to ED with acute migraine headache, who were randomized to receive intravenous metoclopramide at 10 mg or intravenous prochlorperazine at 10 mg or placebo. Primary outcome of the study was a change in pain score at 30 minutes, as well as nausea and sedation at 30 minutes. Secondary outcomes: need for rescue analgesia, overall patient satisfaction, and willingness to be treated again with any of the medications. When it comes to results, as follows. Change in pain score at 30 minutes was much more prominent in prochlorperazine group. All groups had essentially similar initial pain scores, but prochlorperazine group had significantly greater change in pain score at 1, metoclopramide at 4, and placebo at 6. Clinical success, defined as near complete or complete resolution of headache, was more prominent in prochlorperazine group, 82% of patients, versus 46% of patients in metoclopramide group, or 29% of placebo. Prochlorperazine group patients had significantly less nausea, and lastly, 4 patients had to return to the emergency department within 24 hours for recurrence of headache. None of these patients were part of the prochlorperazine group. 3 patients was from metoclopramide group, and 1 patient was from placebo. Mind you, it was 1995. However, doctor concluded at that time that IV prochlorperazine at 10 mg is superior to metoclopramide when it comes to managing headache related to migraine type of headaches. We'll leave neuroleptics for a second and we'll move to the third class of fairly frequently used medication in the emergency department. We're going to talk about triptans. Triptans are agonists of serotonergic receptors, predominantly 5-HT1. The way these triptans work is by mediating neuroinflammation, almost similar as neuroleptic, even though triptans have a fairly prominent and fairly potent vasoconstrictive effect. However, when it comes to migraine headache, they modulate neuroinflammation by decreased amount of vasoactive peptide, which prevents vasodilation as well. Triptans can be administered subcutaneously, intranasally, or orally. Unfortunately, headache relapse with the sumatriptans are relatively high. It happens between 40 to 75%. Side effects affect about 1 to 10% of patients and are chest pain, chest tightness, sweating, and dizziness. It's always good to have a little reminder what constitutes contraindications for triptan use. Since triptans are fairly potent vasoconstrictive agent, conditions such as severe ischemic heart disease, Prinzmetal angina, history of multiple risk factors of atherosclerotic vascular disease, severe primary vasculopathies are contraindication, as well as use of ergot preparation within 24 hours, use of monoamine oxidase inhibitors or SSRIs, and as well as use of triptans in 24 hours. Now, let's review some evidence that either supports or refutes use of triptans in our emergency department. The primarily agent that is most commonly being studied and most commonly used in our EDs is sumatriptan. We started with Dr. Friedman and colleague, who in 2005 put together a randomized double-blind controlled trial comparing intravenous metoclopramide given at 20 mg up to 4 doses up to 2 hours in comparison to 6 mg of subcutaneously given sumatriptan for patient presented to emergency department with acute migraine headache. Primary outcome, change in pain score at 2 hours. However, this change of pain score was noted at baseline and then every 20 minutes up to 2 hours. Secondary outcomes include rates of rescue analgesia, patient satisfaction, headache-free interval, and recurrence of the headaches. So results of the study showed that sumatriptan group had prominent but slightly less change in pain score at 2 hours in comparison to metoclopramide. Change of pain score was by 6 points in sumatriptan group versus 7 points in metoclopramide group. At 24 hours, change in pain score was still prominent, but less prominent in sumatriptan group in comparison to metoclopramide group, 5 versus 6. At 2 hours, while patients still in ED, pain-free rates, which means headache-free, were affecting 35% of patients who received sumatriptan versus 59% of patients who received metoclopramide. Surprisingly, to me at least, rates of side effects were essentially similar between two groups: weakness, dizziness, drowsiness, and easy restlessness. Patients receiving sumatriptan did not experience any chest pain. Author's conclusion was that metoclopramide is actually superior to sumatriptan. One thing is, though, I want you to bear in mind that metoclopramide was given at 20 mg up to 4 doses up to 4 hours, and sumatriptan was given once as a single dose. Similarly, Talabi and colleagues conducted a prospective randomized double-blind trial of 124 patients who received intravenous metoclopramide at 20 milligram as a single dose in comparison to 6 milligram of sumatriptan given subcutaneously. Primary outcome of the study was a change in the pain score at 60 minutes. Results showed that both groups had significant and very quick and prominent change in pain score. However, metoclopramide group had slightly greater change in pain score, which translates into slightly better analgesic efficacy. In addition, metoclopramide group had faster onset of analgesia in comparison to metoclopramide. Kostick and colleagues conducted a prospective randomized double-blind trial of comparing intravenous prochlorperazine at 10 milligram dose with 12.5 milligram of diphenhydramine that were compared to sumatriptan at 6 milligram subcutaneously. Both patients received 500 ml of normosaline prior to a study. Primary outcome, change in pain score at baseline and every 20 minutes up to 80 minutes. And results of the study showed that at 80 minutes, change in the pain score in prochlorperazine group was 73 millimeter versus 50 millimeters in sumatriptan group. And both groups had similar side effects such as sedation, nausea, and headache recurrence rate. Others concluded that prochlorperazine with diphenhydramine is superior and works better than single subcutaneous injection of sumatriptan. Just recently, I just want to bring to your attention that FDA approved a combination of sumatriptan and naproxen sodium as a tablet for acute treatment of migraine headache in adult patient and adolescents and children greater than or older, I should say, than 12 years of age. And I can say the dosing is for adults, dose is 81 tablet, which is 85 milligram of sumatriptan over 500 milligram of naproxen, with a maximum dose of 2 tablets per 24 hours, given at least 2 hours apart, no less than 2 hours apart. Pediatric dosing with the adolescents and children whose age is greater than 12 is a single tablet at 10 milligram over 60 milligram with a maximum dose, total maximum dose per 24 hours is 85 milligram of sumatriptan and 500 milligram of naproxen. Several studies, some of the pharmaceutical companies sponsored, particularly in the phase 3 trial, showed that combination of sumatriptan and naproxen was better than placebo at 2 hours analgesic efficacy in at 2 hours pain-free episodes in adolescents and adults. Similarly, phase 3 randomized controlled trial showed that combination of sumatriptan and naproxen was more analgesically effective than individual agents alone with respect to controlling and elucidating sustained free headache episode at 2 and 24 hours. Some of the side effects related to use of combination of sumatriptan and naproxen are hot flashes, myalgias, and dizziness. So moving along, we talked about NSAIDs, we did cover neuroleptics, we talked about sumatriptans and triptans in general. Now we're going to move to butyrophenones. Act as a dopamine receptor antagonist, works towards limbic system, towards basal ganglia, and they all have prominent anti-dopaminergic effects, as well as anti-serotonergic as well. Commonly representative of the class are haldol and droperidol, which can be given, both of the medication can be given intramuscular or intravenously. They have a similar effect of neuroleptics as neuroleptics on the headache. However, this class of medication are notoriously known to have significant rates of extrapyramidal symptoms, such as side effects, such as sedation, nausea occasionally, and restlessness, translated as akathisia. Now let's look at some of the evidence that supporting use of butyrophenones, either haldol or droperidol in our emergency departments for migraine headache. Just recently, in 2015, this year, Dr. Gaffigan and colleagues put together a prospective randomized controlled trial comparing intravenous haloperidol at 5 milligram dose to intravenous metoclopramide at 10 milligram dose after all patients received 25 milligram of diphenhydramine. Patients, 64 patients, age of 18 to 50, presented to emergency department with acute migraine headache, were randomized to receive either of the medication. Primary outcome of the studies was pain, nausea, sedation, restlessness that were assessed at frequency every 20 minutes up to 80 minutes maximum. Results of the study showed that at any given point, at 20 minutes, 40, 60, and 80 minutes, change in pain score between intravenous Haldol group and intravenous metoclopramide group were essentially the same. However, haloperidol group had required significantly less rescue medication than metoclopramide group, 3% of Haldol group versus 24% in metoclopramide group. Very importantly, none of the patients who received Haldol had any change in their QT intervals or had a QTC prolongations. However, at 48 hours follow-up with the phone calls, more patients in haloperidol group were complaining about restlessness and akathisia, 43% of those patients in comparison to only 10% patient in metoclopramide group. Hankanimi and colleagues conducted a randomized double-blind placebo-controlled trial of 40 patients presented to emergency department with migraine who were randomized to receive haloperidol, 5 milligram and 500 ml of normoselin versus normoselin, just given as a 500 ml bolus. Primary outcome of the study, change in pain score at 1 hour and 3 hours. And the results of the study showed the group receiving haloperidol had significantly greater change in pain score at 1 hour and 2 hours, 2.2 versus 6.3. Pain relief was significantly more prominent in haloperidol group, 80% for patients versus 15% in placebo group. However, up to 80% of patients who received haloperidol were complaining about sedation and had significant degree of akathisia, of which 16% of patients found those side effects to be intolerable and had to terminate their treatment. 2015, Thomas and colleagues conducted a Medline search of 60 years worth of data, evaluated randomized controlled trial comparing droperidol, either with placebo or active comparator, with respect to analgesic efficacy and safety on relieving migraine headache patient presenting to emergency department. Primary outcome of the review were acute headache improvement and secondary outcome frequency of extrapyramidal side effects, somnolence, sedation, and cardiac events. 5 manuscripts were eligible for evaluation, which showed that droperidol was significantly better than placebo in relieving headache of migraine origin, and droperidol was found to be as effective as prochlorperazine, meperidine, or olanzapine. Doses most commonly implemented were 2.5 milligram or 5 milligram intravenously and intramuscularly. Major side effects related to droperidol administration were akathisia and sedation. However, none of the patients experienced any cardiac arrhythmias, no cardiac adverse effect, and I believe none of the patients had any changes in their QT or QTC intervals on EKGs. Lastly, Minder and colleagues conducted a prospective randomized controlled trial of 168 patients, of whom 82 patients received droperidol, either intramuscularly at a dose of 5 milligram or intravenously at a dose of 2.5 milligram. And this group was compared to 86 patients who received prochlorperazine, either intramuscularly at a dose of 10 milligram or intravenously at a dose of 10 milligram. Primary outcome of the study was a change in pain score at 30 and 60 minutes, and secondary outcomes were rate of side effects, particularly sedation, restlessness, akathisia, and any other type of extrapyramidal symptoms. When it comes to results evaluation, droperidol group did significantly better. At 30 minutes, 61% of patients in droperidol group obtained at least 50% reduction of the headache, in comparison to 44% in prochlorperazine group. At 60 minutes, 81% decrease in pain score was noted in droperidol group versus 69% in prochlorperazine group. At 60 minutes, 90% of patients in droperidol group obtained at least 50% reduction in headache intensity, in comparison to 66% in prochlorperazine group. There were no difference with respect to analgesic efficacy between intramuscular dosing or intravenous dosing. However, droperidol group had slightly higher rate of dystonia, akathisia, and sedation, 15% of patients versus 9% of patients in prochlorperazine group. Moving on to very controversial subject, opioids and their role in management of acute headaches, acute migraine headache in the emergency department. Based on available data, in particular based on the recent guidelines published by American Academy of Neurologists, opioids are not recommended for routine use in treating acute primary headache disorders in the emergency department. and there should be reserved only for severe refractory headaches. Administration of opioids is associated with development of chronic migraine state known as the status migrainosus. In addition, administration of opioids for patients with a headache leads to longer stay in the emergency department and fairly frequent recurrence of the headache for which patient is coming back. Available data, at least for the past 20 years, was heavily geared towards evaluating role of meperidine, either intravenously or intramuscularly, in comparison to ketorolac, phenothiazines, and other antiemetic agents, and showed that meperidine was actually equally effective to ketorolac, but was significantly inferior to triptans, phenothiazines, butyrophenones. Problem is meperidine has significantly impressive rates of side effects, is very euphoric and potential addictive. Thus, its use should be not supported, and I know with the fact of it that nobody uses meperidine for headaches in the emergency department. One of the studies conducted this year was by McCarthy and colleague, who conducted a retrospective chart review of 574 patients, consecutive patients, who presented to emergency department with primary headache disorders. And their primary outcome of the study was to evaluate whether or not physicians were following the guidelines with respect to prescribing parenteral opioid or non-opioid analgesics. And just with respect to factor what patient received, what would be the outcomes with respect to headache intensity, recurrence rate, and side effects. And results showed that 52% of patients received parenteral non-opioid analgesia and 22% of patients received parenteral opioid analgesia. Those patients who received opioid analgesia had longer length of stay, median about 5 hours in comparison to 3.9 hours of non-opioid analgesics, and patients receiving opioids had higher rates of return to ED for the recurrence of the headaches. 7.6% of patients in opioid group versus 3% of patients in non-opioid group. Steroids. Based on available data, steroid use for patients with acute migraine headache is geared toward prevention of recurrence of headache in patients with acute migraine headache, phenomenon which is apparently affecting 2/3 of the patients with migraine headache in the first 48 hours post-treatment. The way that steroids work is by suppression of inflammatory response, thus part of the neurogenic inflammation from prolonged migraine headache. Would Emanuel and colleagues conducted a 65 years worth of data, systematic review, evaluating feasibility, benefits, safety, and analgesic efficacy of steroids given for patients presenting to emergency department in migraine attacks. They were able to extrapolate 25 studies with about 4,000 patients each. 52% of the studies were ED-based, 56% include randomized controlled trials, and 4 systematic reviews. Results of this systematic review showed that the outcomes of the 19 studies were significantly favoring using of steroids in comparison to active comparator or placebo. 6, which is 24% of the study, showed non-inferiority of using steroids in acute migraine headache in comparison to placebo or active comparator. Patients who received steroids had less recurrence rate of headache at 24 and 72 hours by 30% and 11% respectively. Dexamethasone, known as Decadron, was most frequently used medication in 56% of trials, with the most common dose being 10 milligram, with the range being 4 to 24 milligram. Interestingly enough, authors were able to pull some of the criterion by which they were able to show if patient presents to a emergency department with significantly strong headache, associated with a higher disability, photophobia, migraine-induced hemiplegia, status migrainosus, have incomplete pain relief for prior medication, or having previous history of headache recurrence, this subtype of patient would have great benefit of using intravenous dexamethasone. Lastly, but not least, I find this very, very controversial issue, which finally probably is going to be put to rest. Diphenhydramine, Benadryl, is commonly used as adjunct to antiemetics or antidopaminergic agents, most commonly metoclopramide, in relieving acute migraine headache in the emergency department. However, high-quality trials, randomized controlled trials, are lacking. There's no really good evidence to support its use. So, our colleague, Dr. Friedman, and colleagues put together a randomized double-blind controlled trial of 208 patients who were randomized to receive intravenous diphenhydramine at 50 milligram dose with intravenous metoclopramide at 10 milligram, or another group received placebo and metoclopramide at 10 milligram. Primary outcome of the study was a sustained headache relief at 2 hours in ED and at 48 hours follow-up. Here is the results. Interestingly enough, I need to say that authors conducted a planned interim analysis of data, and board that approved the study initially actually suggested the study will be halted. They basically declare futility of the continuation of the study. And here's the reasons why. Based on available data at 208 patients, diphenhydramine group had similar headache relief or similar change in pain score in 40 patients in diphenhydramine group versus 37% of patients in placebo group at 48 hours. There were no difference in change in pain score at 2 hours in the emergency department between patients receiving diphenhydramine or placebo. 85% of patients versus 76% of patients requested to have the same medication in the future, meaning either diphenhydramine or placebo. There was no difference in length of stay between diphenhydramine and placebo, and both groups, to my great surprise, had similar rates of akathisia. So author's conclusion is that when it comes to metoclopramide, you should not be combining it with diphenhydramine, as diphenhydramine intravenously does not affect outcomes of patients presenting to emergency department with acute migraine headache. So this is the review, and I'm going to summarize everything we talk about this. When it comes to analgesic and non-analgesic classes that we should be at least try to employ or utilize in the emergency department, it boils down to actually 5 classes: NSAIDs, neuroleptics, butyrophenones, triptans, and steroids. Opioids are not advisable for routine use, neither ergots preparations. And here's I'm going to put briefly a short algorithm that I believe should at least use as a framework for your future personal experience when it comes to management of headache. When patient comes into emergency department with a mild headache and they're able to take PO medication, ibuprofen at 400 to 800 milligram, acid in combination with acetaminophen at 1 gram dose, or even sumatriptan, orally or given subcutaneously, is a good way to start. In addition, combination of acetaminophen, aspirin, and caffeine should be considered given patient with mild to moderate headache who are able or capable to take medications PO. As a matter of fact, if you can see it, no barbiturates should be used, such as Fioricet, according to recent guidelines from American Academy of Neurologists, should not be used for managing mild to moderate headache or moderate to severe headache in the emergency department. If patient presents to ED with severe headache and they're not able to tolerate PO medication, they're having severe nausea and vomiting, and you believe they might benefit from intravenous analgesia, here's a tiered approach that I employ in my emergency department. First-line medication are neuroleptics: intravenous metoclopramide as a single agent, intravenous prochlorperazine with diphenhydramine, or chlorpromazine. All this medication should be infused in a time over 30 to 60 minutes, never should be pushed. This medication at times can be combined with ketorolac as a second line, or with sumatriptan, which occasionally can be given as a first-line preparation, especially if patient comes in within an hour of migraine headache. Dose 6 milligrams subcutaneously. They can be repeated at 1 hour at 12 milligrams as well. If nothing works, you move to the third line of medication: intravenous dexamethasone, intravenous magnesium, or intravenous valproic acid. And I usually reserve butyrophenones such as Haldol. I don't have droperidol in my emergency department, but I reserve this medication for intractable headache. And I use Haldol at 2.5 to 5 milligram slow intravenous push. At times I use 500 milliliters of normoxilin, and there's infuse this medication to it. I want to thank you for your attention. I hope you've learned something. I hope this review is going to be useful for your everyday practices, and I look forward to see you next month.